So I wanted to base this presentation from a more personal viewpoint and just explain how I approach my patients' care, as I also have the same diagnosis as a majority of my patients. Those are my disclosures. So just a brief introduction and a bit about my background. So my current patient group is a bit of a variety. I've got haemophilia A and Bs, I've got rare bleeding disorders, platelet disorders, but I also have patients with anticoagulation problems, also lifelong warfarin conditions due to cardiac surgery. And we also have quite a healthy cohort of sickle cell and thalassemia patients, some of those which are transfusion dependent and come to our haematology ward every 3 to 4 weeks for blood transfusions. Before I went to Sheffield, my previous work experience consisted mainly of working at Great Ormond Street Hospital in London and also Birmingham Children's Hospital. And these were with haemophilia patients, but I also did other things such as hemonc, immunology, research and private patients. But a bit more about me. So I have a diagnosis of severe haemophilia A, diagnosed around my first birthday due to big, excessive bruising. No family history either. There's just me and my brother who were affected, but we can't trace any other history back within the family. And due to having a target joint as a child and having many, many ankle bleeds, I have a nice right ankle arthropathy, which is quite painful some days, and sadly today is one of those days. But to explain how my diagnosis influences, affects the care that I give to my patients, one thing that I tend to do, and this is a personal choice, not that anybody told me to do before I started working in haemophilia, is I operate a non-disclosure policy, really. Basically, I don't inform my patients or the families that I have a diagnosis. And this is for a number of reasons, which I'll kind of go through as the presentation goes on. But one of those things that I want to just discuss now is the sheer differences between when I grow up with haemophilia compared to how my patients at the moment grow up, because there's a vast, vast difference. One of those being the treatment products, whereas now you've got endless recombinant, you've got extended half-lives, you've got emicizumab coming up, you've got gene therapy. Back when I was growing up and started having treatment, this was late 80s, early 90s. We had plasma products, and these were big volume products. These were 10, 20, 30 mils just for a basic prophylaxis dose as well. There's more options for personal prophylaxis these days as well. You can have it before sport, you can tailor it to basically what your week persists of. Back then, you had it kind of on demand mainly before prophylaxis kicked in, and it was quite late for me personally kicking in. And the big one, which is sports. Now, when I was young, I was highly, highly discouraged from doing any kind of sport whatsoever apart from swimming. So in PE lessons at school, I basically either sat out doing nothing, I refereed the rugby and football, which was interesting to say the least. But now we encourage all of our patients, and me included with mine, we encourage them all to do as much sport as possible within reason. But the important thing from that previous slide is that I can't compare my experience growing up just because of the sheer difference. And one of my examples I want to use is a bleed. So to me, and I'm sure a lot of people would agree, a bleed is a very personal thing for people with haemophilia and other bleeding disorders. It feels different to everyone, and everyone perceives it in a different way as well. So, for example, if my patients were aware of my diagnosis and they came to me and had an elbow bleed, is it right and can I say, well, I had an elbow bleed a couple of weeks ago, I did this, I was fine, didn't hurt me, so off you go. But I can't say that. I have to treat my patients and care for them the way that they're feeling and the problems that they're having at the time. And another point and something to think about, and it is thinking a bit highly of myself, I know, and unlikely. But if the families were aware of my diagnosis, is there a potential for a certain subgroup to kind of latch onto it? We all have those patients that get on with it, go for it, do whatever they like, and life's not a problem. But we also have those patients that struggle. Every day's a battle. There's constant problems, they're very nervous, and they really do find it difficult to deal with. So, do I want to risk those groups of patients basing their child's haemophilia care on what I do? Well, Shaun does this for this, and he did this, and he's fine, so we'll do this. And again, I don't want that. And there's a particular subgroup of patients as well, which I think are quite vulnerable, and that's the newly diagnosed families with no family history. It's a highly stressful, uncertain, and vulnerable time for them. And I don't want them to base what they do on me. I want them to make the decisions and live their lives from the good knowledge base that myself and the hospital, the doctors, everyone involved in that child's care has given them. So why did I choose haemophilia nursing? So I started in haemophilia about probably 6-7 years ago at various different hospitals along the way. And it's due to the fact that I had a fantastic haemophilia nurse growing up who's long since retired, but she was brilliant. She was tough but fair. You didn't want to miss any clinic appointments with her, and if you didn't fill in your treatment records, and you paid for it. But she was very, very supportive, and towards me, my brother, and my family, especially through a particular dark time we went through. And she was always there. And I thought to myself, as I started my nursing career, well, that could be me. Why can't I do that? Why can't I use my experience to help the next generations of haemophilia patients and bleeding disorder patients along the way? But how do I do it? How do I use what I know, what my experiences are, to achieve this goal? So, one of the most important things, venepuncture and cannulation, which I think everyone would agree is probably the most important clinical skill to have within this specialty and is so crucial. So I take it very seriously, and over the years I've tried to develop this skill to the highest level I can possibly get it. And I think I do all right. A lot of the doctors and nurses will come to me in the hospital if there's any difficult ones, and 9 times out of 10, you know, I'm pretty good, but not the best. But I learn from the best. But it also comes back from memories. So I still remember sitting in this big faux leather chair at the haemophilia centre when I grew up, because we didn't have home treatment back then, and having multiple unsuccessful attempts to have these injections as well, and just the pain and the trauma involved. And I remember my mum used to be the one who used to give me my treatments, and my dad tried to learn. And I remember one afternoon we were at the hospital, and I think he tried about 9 times, bless him, and he still couldn't do it. And this was England in the early 90s. You can get away with that kind of thing, and no one would even ask. But after the first 6 times, you were just sitting there wincing away with your arm out, and after the 6th time, you were just sitting there like bored out of your mind, just wishing he would hurry up and get it done so you can go home. But I remember my experiences, and that's why I take this particular clinical skill quite seriously. The next one is bleeds, just for the simple fact that I know what it feels like to have them. But again, previously I said personal perception is different, but I can still relate and empathise with what the patient's feeling, and I can understand the emotional aspect and the uncertainty involved with this as well. The emotional support as well, which is again another crucial part of haemophilia care. And you know, I do understand particular situations that this patient group encounter in their life, whether it be school, high school, sports, friends going on holiday, because I've been there myself, so I can relate to that. So to use my personal experience with this, I try and have the most positive impact on patients' lives that I can do. And I use different approaches to try and achieve this. I use family-centred care, but I also work in a collective partnership with patients and the families as well. So I'm working alongside the parents for the best interests of their child, which I think is really important to do, and I don't just tell them what to do and expect them to follow. But perhaps I use approaches like these because that was how I was taught at university, and I think it's the right thing to do. But maybe as well, I would have liked to have had that a bit more as I was growing up, because again, haemophilia care was very different in the late 80s. But another interesting thing that I realised as I was going through haemophilia nursing is it taught me more about how to look after myself, how to improve my knowledge base in certain situations, why prophylaxis is important, when to do prophylaxis before certain things as well. But overall, doing this role, it does give you a different perspective, maybe, compared to other people. And hopefully I've explained why it can have a positive effect on the patients. But a question is, does having the same diagnosis as our patients make us better than healthcare professionals who don't have that diagnosis? And the very, very easy answer is no, of course not. Everybody in this room, in this congress, worldwide who works within this specialty offers something unique, different and positive to their patients, whether it be high level of clinical skills, the confidence and support that you give them, and also just your general people skills, compassion. This, to me, personally, just offers a different way in and a different way to help and treat the patients. So to finish with, my goal, and this is how I approach all of my patients' care, whoever they are, is I always try and treat the patients how I would have wanted to be treated at their age while sitting in that chair at the centre, because I still, and part of me always will, remember how it feels to be in that position. Thank you very much.